I'm welcoming Dr. Jay Geary today. We're here to talk about all things high-risk PE at the ACC meeting at New Orleans. Dr. Jay Geary serves as Associate Director of the Cath Lab at Penn. Thanks for joining us.
Thanks so much for the opportunity, Sean. I'm really looking forward to the discussion.
Yeah, today's a really exciting day, I think, for the field, and particularly with regard to high-risk PE patients after seeing this data reported. You were integral, obviously, to this study, highest enroller in the study. Also, Jay, you were a primary author on a scientific statement regarding high-risk PE before the study even enrolled. Can you talk a bit about that?
Yeah, if you go back to 2018 and 19, a group of us on behalf of the American Heart Association sought to lay out investigative priorities in acute pulmonary embolism, and specifically as they related to potential transcatheter therapies, which were really at an inflection point in terms of the revolution at that time. Mm-hmm. We thought about it in different ways, but we did make some specific recommendations regarding initial attempts to study the high-risk PE population. It's a very complex group to study, and it's for many reasons. They are very sick, they may be on pressors, they may even be having arrest, and so consent issues are sometimes an issue. Secondly, you sometimes have to use tiered therapies or combined therapeutic approaches. In our hospital, sometimes we have a patient on mechanical circulatory support, then we may be proceeding with a transcatheter therapy or even a surgery. All these things are all mashed together in this high-risk PE population. We're trying to treat them. It does create difficulties, at least at the stage we're at in 2019 and probably where we're at up until today, of creating the cleanest randomized approach, at least as an initial step. So we did make the recommendation at that point, let's at least start and try to get some prospective data on the table here to help guide ourselves in this group of patients who are dying at remarkably high rates. And how do we cut that mortality? We got to do it by investigating. And with that, we made the recommendation, if we could design a study to start with that investigates an interventional therapy, let's also aim to capture at those same hospitals everybody else who's treated without that. So it's kind of a prospective registry approach. We're agreeing with the fact that we are going to be selecting patients for different therapies, but we may well be able to get context around who these patients who are getting transcatheter therapies are, which is important. And secondly, how they do, and then what the context is in those same hospitals. Importantly, we also made the recommendation that let's get real specific, if we're going to do this, on what our endpoints are and what the benchmarks we're trying to achieve are based on the current observational literature that's there over the last decade or so. So you probably doesn't surprise you, this was the conceit of the FLAME study, it turned out.
Mm-hmm. Yep. And G, looking now at our 50-patient results, the study terminated at the interim due to overwhelmingly reaching the primary endpoint versus predefined performance goal. We're looking at the data of the FlowTriever patients and the context arm patients. I thought one place to start was validation of those observational data that preceded this and that helped form your performance goals. How did that stack up against what we saw in the context arm?
Yeah, so we recently published the meta-analysis that informed the benchmark performance goals for all of the endpoints in the FLAME study. The most important one that we really need to talk about is in-hospital mortality.
Of course, yeah.
That's the big one. And in our benchmark, data, it was 29% in hospital mortality. This was 10 years of observational studies in the literature. It's a reasonable assumption if you look at even older studies of high-risk PE. You're kind of always in that 20 to 50% mortality range. So it passed the sanity test, the 29% mortality rate for benchmark. It was interesting because when you looked at the context patients in the FLAME study, who were largely treated with TPA. It's a sick population, a lot of advanced shock, and 70% of them got TPA, which is a high guideline rec for what it's worth right now. So not surprising treatment. They had 30% mortality. It's almost exactly what we had studied.
Yes.
So it's kind of remarkable how the context arm looked like our meta-analysis.
Yes.
And now, if you want me to get right into it with what we saw in the FlowTriever arm.
Yes.
I want you to be careful. We have to bear in mind these were patients that were selected by expert PERT teams to get FlowTriever. That being said, the survival was remarkable in what was an ill population, 75% advanced shock. These were truly massive PE patients. And massive P is a spectrum, so certainly we can argue, are they in the middle of the spectrum, are they on the high end of the spectrum? But they only had a 2% mortality. So it did kind of bear out this concept that, to me, that systemic TPA, despite what the guideline rec says right now, is not the best answer in an algorithmic fashion. So if you are in a hospital and you've got a PERT team, don't build your algorithm and just do not pass go straight to systemic TPA in the high-risk population. Is it going to have a role? Of course it's going to have a role in some patients.
Of course.
But we got to be more nuanced. We got to think carefully about how we really help these patients and direct the right therapy to the right patient. And I think we saw in FLAME that in these expert PERT centers, they were able to select those patients out that would benefit from large bore embolectomy with FlowTriever, and they were successful.
You know, one common misconception, I think, when people look at algorithms and perhaps adhere to some guidelines from prior data is, well, FlowTriever is for patients who are contraindicated to lytics. You mentioned that this study was in the FlowTriever arm patients selected by expert operators, but we didn't necessarily see overwhelming lytic contraindication in that arm. Can you speak to that?
Yeah, no, it's a great point. It went against our expectations because we knew this was kind of two prospective registries really that we were looking at, and we expected the FlowTriever patients to have a lot of lytic contraindications because maybe that's why they were being selected for FlowTriever. Yep. In fact, at these centers, they were willing to put patients into the study, even who seemed like maybe okay candidates for systemic lysis. And I think that, again, broadens our horizon around this concept of algorithmically using systemic TPA. This is where we need to move past that era. We need to use the tools at our disposal to decrease the 30% in-hospital mortality rate in this population. Unacceptably high, hasn't changed in 3 decades. We're not doing something right with how the guidelines are written around systemic TPA right now.
Yes.
And I think this is a major step forward to, frankly, call that into question.
Yes. This study tested specifically FlowTriever therapy as a treatment modality, which is large bore aspiration thrombectomy. One concern, TPA given systemically obviously carries risk of intracranial hemorrhage, major bleed. Blood loss is a concern people have when doing a large bore aspiration. FlowTriever is unique in the sense that it's coupled with the FlowSaver device. Talk to me about what we saw in terms of blood loss and also utilization of that FlowSaver in the study.
Yeah, the FlowSaver came online during the conduct of the study. Mm-hmm. So in the first few early patients, it wasn't used, but then it ended up being used in the majority of the patients through the study. The whole idea around FlowSaver is a simple idea. It's basically the blood you're sucking out, 50 to 60 cc's at a time, you're going to reinfuse it in. It's not complicated. And what you find is when you reinfuse it in, not surprisingly, hemoglobins aren't dropping. It's kind of a simple concept. It did minimize the blood loss on the FlowTriever side. Importantly, the issues we have with systemic TPA regarding bleeding aren't just like, passive blood loss, even if the FlowSaver wasn't being used. The issue we have is complicated blood loss. Mm-hmm. That means, in worst cases, intracranial hemorrhage, GI bleeds, things happening in the body that have a major impact on the patient and often need treatment. So that's a big issue with systemic TPA.
Let me get you on this question, Jay.
Yeah.
This is the largest subset of patients we've looked at rigorously with this scientific question. What happens now? Did we start seeing practice changes? How does this challenge the status quo in terms of guidelines?
I would say that to answer both of the questions, the first is this really puts the onus on hospitals to start really thinking about how they build their teams and resources to take care of PE. Yeah. And I totally understand that every hospital, there's almost 5,000 hospitals in America, are not going to necessarily have the resources to do the type of work that were done in these 11 hospitals in FLAME. However, we live in a community where you can try to build out your referral base, your hub and spoke models to try to partner with hospitals that can do that, and then come up with localized practices to provide better care for your patients that could involve advanced transcatheter therapies, including FlowTriever. I think that's a key takeaway there. Secondly, with the guidelines, it's hard to change guidelines, for an individual device all the way up the line to level 1 in the absence of randomized data, because that's kind of how, or at least the level of evidence, the 1A data you don't usually get without randomized. That being said, I think that the way the guidelines are written now, with regard to systemic TPA having this position of primacy
Yes.
over transcatheter therapies, over surgical embolectomy, it's not logical right now, and I think that Flame hopefully will have some impact on that portion of things at least.
Jay, as I said at the start of our conversation, it's a really exciting, dynamic time.
Yep.
I thank you for your expertise, for your leadership, and for elevating our field.
Thanks so much for the opportunity. It's been a lot of fun.
Thanks.
Great.